Okay, so this is week 2, part 2. In part 2, we're going to be talking about heart failure and cardiac defects in the pediatric population, and then we'll end by talking a little bit about infective bacterial endocarditis. All right, so we'll begin by talking about heart failure. So heart failure occurs when the heart is not able to pump an adequate amount of blood to the systemic circulation at its normal filling pressures in order to meet the body's metabolic demands. So then in children, heart failure occurs most frequently secondary to a congenital heart defect. So it's usually the result of a congenital heart defect, or it's the result of a structural abnormality. And because of that abnormality, there may be an increased volume load or an increased pressure load on the ventricles. And you'll see this when we talk about the more specific defects. So then, with congenital heart disease, there are two things that happen as a result of a cardiac defect and altered hemodynamics. There's heart failure and there's hypoxemia that usually results. All right, so I'm going to refer to this diagram, and I think it's a very good diagram. It's in your book, so you can go back and refer to it. I think the best way to describe the classification of heart defects is more on the second level. In the second level, or the second tier, it really pretty much describes what's happening with the defect overall. So under acyanotic defects, there's defects where there's increased pulmonary blood flow, or there's defects where there's obstruction to blood flow from the ventricles. So the second tier really describes what's going on with the defect. And then under the cyanotic, there's defects where there's decreased pulmonary blood flow and mixed blood flow. So in this lecture, I will be focusing on those defects where there's increased pulmonary blood flow, there's an obstruction to blood flow from the ventricles, and then I'll end by talking about defects where there's decreased pulmonary blood flow. All right? So the first defects I'm going to be talking about are those defects where there's increased pulmonary blood flow. And examples of those defects are atrial septal defect, or ASD, ventricular septal defect, or VSD, or patent ductus arteriosus, or PDA, and last, atrioventricular canal, or AVC or AVD. And then I'll move on and talk about defects where there's some kind of obstruction to blood flow from the ventricles, and those include coarctation of the aorta, or COA, aortic stenosis, or AS, and pulmonic stenosis, PS. Then we'll end by talking about defects where there's decreased pulmonary blood flow, and examples of would be tetralogy of Fallot, or TOF, and tricuspid atresia, or TA. All right. So, so a congenital heart disease occurs when there is a defect either in the heart or the great vessels, or there is a persistent structure after birth, such as a patent ductus arteriosus. So there are mild defects, moderate defects, and severe defects. Most children have mild defects. Many children are asymptomatic and may not require treatment with mild defects. And examples of mild defects would be a small PDA, patent ductus arteriosus, or a small ventricular septal defect, or a VSD, or a mild pulmonic stenosis, or a PS. Now, with moderate defects, most children will be symptomatic during childhood when there is increased activity level. So examples of moderate defects would be mild aortic stenosis, moderate pulmonic stenosis, coarctation of the aorta, and moderate ASD, or atrial septal defect. Okay, so now severe defects will include all of the cyanotic and other complex defects such as your AVC. So severe defects will include all of these defects, and then the atrioventricular canal. So infants identified in the newborn period or early infancy are usually severely ill, and that will require surgical intervention. All right, so we're going to move on, and we're going to talk about these 4 defects, which where there is increased pulmonary blood flow. All right. Okay, the first defect we're going to talk about is a patent ductus arteriosus. So, and right here is where the defect is. So, first of all, I want to remind you, with this defect, there's an increased pulmonary blood flow, and it's usually, the PDA is usually seen in preterm infants. So a PDA is a common congenital defect that is caused by persistent fetal circulation. So what happens is that the artery, the artery connecting the aorta and the pulmonary artery don't close within the first week of life. As a result, you have left to right shunting of blood. So the blood flows from the higher pressure aorta to the higher pressure aorta to the lower pressure pulmonary artery. And as a result, there's increased blood volume that goes to the lungs. That increased blood volume is recirculated to the lungs and returned to the left atrium and left ventricle. So there is increased pulmonary vascular congestion, and there is an increased workload on the left side of the heart because of the increased blood volume. So then the clinical manifestations are going to really depend on the size of the PDA. So the infant may be asymptomatic, or they may show signs of congestive heart failures. So the larger the hole, they'll probably show signs of heart failure. The smaller the hole, they may be asymptomatic. So when you do have congestive heart failure, a murmur will be heard, and there will be widening pulse pressures, and there'll be bounding pulses because of that increased blood volume. So now the surgical treatment would be ligation of the PDA via a thoracotomy. That would be really the last resort. Non-surgical treatment would be, and this would be the first choice, would be to place a coil at the side of the opening. So they have these little small coil they put right here in the opening. It's done in the cath lab, and they put the coil there at the opening, and then a blood clot forms and it blocks it. But the first treat, the first way they're going to treat before they decide to do the non-surgical using the coil would be medical management, and that would be with indomethacin, which is a prostaglandin inhibitor. What it does, it closes the PDA in premature infants and some newborns. So they'll usually give up to 4 doses, and then if the 4th dose doesn't close the PDA, then they would go to the coils. All right, our next defect is our atrial septal defect, or an ASD, and that's where you have an abnormal opening between your left and right atrium. So in this case, there's oxygenated blood is shunted from the left side of the heart to the right side of the heart. So you have increased flow of blood volume passes through the pulmonary artery and then into the lung. So you have blood coming from the left side over into the pulmonary artery and into the lungs. So with small defects, the infant may not exhibit symptoms and may not require surgical intervention. With mild defects, many may be asymptomatic and may not require treatment. And with moderate defects, most children will be symptomatic, especially during childhood, because they're much more active and their oxygen demands are higher. So that's when you will see some symptoms. Now with large defects, you're going to definitely have congestive heart failure or heart failure. The child will tire easily. They'll have poor growth. You're definitely going to hear a murmur. The first treatment would be non-surgical treatment, which the defect will be closed with a special device during cardiac catheterization, or they would put a surgical patch to close the opening. They would use a Dacron patch or a pericardial patch for moderate to large defects. I'm not going to really focus on the surgical interventions. I'm just going to focus on the defect and the signs, symptoms, and the nursing care and management. So usually after they've had, whether it's non-surgical treatment or surgical treatment, they would receive a low-dose aspirin post-op for up to 6 months. And when they do have any surgical intervention, there's a low mortality rate, which is good. All right, the next defect we're going to talk about is atrioventricular canal, or AVC or AVD. This is still a defect where there's increased pulmonary blood flow. So with the AVC, it's one of the most common cardiac defects in children who have Down syndrome. And as you can see, there is a low atrial septal defect. So there's no atrium. There's a high ventricular septal defect, so there's no ventricular septum. And then also, this you cannot see, is the mitral and the tricuspid valves are cleft, or they're split, so they're not fused. So what happens is you can see that there is a very large opening that allows blood to flow between all 4 chambers. So what's happening is that you're having oxygenated and unoxygenated blood mix. So really the direction and the pathway of the blood flow is going to be determined by pulmonary and systemic resistance, left and right ventricular pressures, and the compliance in each chamber, the compliance of each chamber. So however, the blood flow generally is left to right shunting. You have left to right shunting of blood. So generally you have the blood flows going from the left to right. So the clinical manifestations then are always going to be related to the increased pulmonary blood flow through the lungs, which results in pulmonary edema. So the symptoms are caused by the increased pulmonary blood flow. So you're going to have moderate to severe heart failure. So you're going to hear a murmur. Usually the palliative treatment would be pulmonary artery banding is sometimes done in small infants for severe symptoms. So infants who have severe symptoms and they're having all this blood volume going to their lungs, and they're having difficulty breathing, what they would do would be palliative treatment, where they would do pulmonary artery banding. They would put a band around this area so less blood is going to the lungs. They would do that first, and then once the baby is stable and has gained enough weight, then they would do repair the other defects, the rest of the defects. And usually surgical treatment, they would put patches placed over the atrial and septal defects, and they would repair the valve tissue. The valve tissue is used to form functioning valves. So once again, you don't really need to know much about the surgical interventions. They just put patches. I just want you to know about the defects themselves. So the last defect where there's increased pulmonary blood flow then is the ventricular septal defect. Once again, or VSD, once again, there's an abnormal opening between the left and right ventricle. So the size of the defect is going to vary. So it can vary. It can be very small to a pinhole to a very large where there's no septum at all. So then the symptoms are going to depend on the size of that defect. All right. So the larger the defect, the more blood is going to be going into the lungs. All right. The smaller defect, they probably won't be symptomatic. So now, because the high pressure within the left ventricle, and because there's more resistance in the systemic arterial circulation, you're going to have left to right shunting of blood. So the increased blood flow through the defect and into the pulmonary artery, you're going to have more volume to the lungs. Okay? So with small defects, they're thought to close by themselves within the first year of life. So, if they're not having symptoms, you're going to wait. Heart failure is common when you have a larger defect, and you're definitely going to hear a murmur. Okay, so now we are moving on to defects where there's an obstruction of blood flow from the ventricles. Okay? So coarctation of the aorta, or COA, as you can see, there is narrowing at the aortic arch. So there's a stenotic area, and it's near the ductus arteriosus. So, and because of that narrowing, it results in increased pressure proximal to the defect. Increased pressure proximal to the defect. The head, so there's increased pressure in the head and upper extremities, and there's decreased pressure distal to the obstruction. So there's decreased pressure distal to the obstruction. So there's decreased pressure in the body and the lower extremities. So with that in mind, so the infant may have high blood pressure and bounding pulses in the arms, and weak or absent femoral pulses and cool lower extremities, because you have increased pressure proximal to the defect. So the head, you're having increased pressure to the head and upper extremities, so you're going to have higher blood pressure and bounding pulses in your arms, right? And then again, you're going to have decreased pressure distal to the obstruction, so you're going to have weak or absent femoral pulses and cool extremities. So the clinical manifestations then are infants will show signs of heart failure. Older children may experience dizziness and headache, fainting, and nosebleeds from hypertension. So these children are at risk for hypertension, rupture of the aorta, and aortic aneurysm, or stroke. So non-surgical treatment would be balloon angioplasty is the primary intervention for children and infants. And for teens, they would put a stent may be placed, and surgical treatment would be to repair the coarcted portion with an end-to-end anastomosis or end-to-end anastomosis or enlargement of the constricted section using a graft or a prosthetic material, or they may use a portion of the left subclavian artery. But usually their non-surgical intervention is the intervention of choice, where they do a balloon angioplasty and stent for infants and young children, and stents for adolescents. So those are the preferred interventions. All right. Our next defect where there's obstruction of blood flow from the ventricle would be an aortic stenosis. So again, this is a defect where there's an obstruction of blood flow from the ventricle. So you have aortic stenosis here. So blood is having difficulty leaving the ventricle. So you have narrowing at the aortic valve, at the aortic valve. So it results in obstruction of blood flow in the left ventricle. So you're having decreased cardiac output, right? You have left ventricular hypertrophy because your left ventricle is working harder, and you have pulmonary congestion because blood is backing up into your to your lungs. So because of this backup, there's extra workload on the left ventricle, and that's why you have left ventricular hypertrophy. And that's really pretty much a prominent feature with this defect. So if the ventricle fails, then you're going to have left arterial pressure will increase, which leads to increased pressure in the pulmonary veins, and pulmonary edema ensues. So then the clinical manifestations would be infants with severe defects may show signs of decreased cardiac output. So symptoms, then, I want you to think of what kinds of symptoms you're going to have with decreased cardiac output. So take a minute to think. And if you said you're going to have decreased or faint pulses, you're going to be hypotensive, you'll be tachycardic, and there will be poor feeding on the infant's part. With children, they're going to have exercise intolerance, chest pain, they'll have dizziness when standing for long periods, and you're definitely going to hear a murmur. So these children are at risk for infective endocarditis, formerly known as bacterial endocarditis. So the non-surgical treatment is the intervention, and that would be balloon angioplasty to open up that narrowed valve. And then there's surgical treatment, which I'm not going to talk about. Our next defect is pulmonic stenosis. This defect, this is an obstruction of blood flow from the ventricle. So as you can see, it's really the opposite of the aortic stenosis, but it's over here. It involves, there's narrowing at the pulmonary artery. Get my cursor here. So the resistance to blood flow causes right ventricle hypertrophy and decreased pulmonary blood flow. So you have less blood flow going to the lungs. So if right ventricular failure develops, then you're going to have right arterial pressure increases, and it may reopen the foramen ovale. So you may have opening of the foramen ovale. So so really what happens, there's shunting of unoxygenated blood into the left atrium, and you're going to have systemic cyanosis will be present. So if pulmonic stenosis is severe, then obviously there's going to be heart failure, and you're going to have systemic venous engorgement is noted. So if you have systemic venous engorgement, then you're going to have signs of backing up. Blood is not getting out of the ventricle, it's backing up. Then you're going to have signs of right-sided heart failure. So clinical manifestations would depend on the degree of the stenosis. Some patients may be asymptomatic if that stenosis is small. Some may have mild cyanosis or heart failure. So infants with severe pulmonic stenosis will be cyanotic because there's not blood is not getting to enough blood is not getting going to the lungs and getting oxygenated. A chest X-ray will reveal an enlarged heart. These children are also at risk for infective endocarditis, which is infection of the valves in the inner lining of the heart. Non-surgical treatment would be the treatment of choice, so they would opt for balloon angioplasty. That's done in the cath lab. There's few complications, and it can safely be done in neonates. And then there's, surgical intervention. All right, so now we're moving on, and we're going to talk about defects where there's decreased pulmonary blood flow. And those two defects we'll be talking about are tetralogy of Fallot, or TOF, and tricuspid atresia. And these are the most common defects. The first one we'll talk about is the tetralogy of Fallot. And the classic form, there's 4 defects. There is it has a ventricular septal defect, which is right here, a pulmonic stenosis, and then the aorta should be right here, but it's an overriding aorta. It gets pushed over. And there is right ventricular hypertrophy right here. So the right ventricle is working hard, so it becomes hypertrophied. So one thing to remember with this defect is that the hemodynamics are going to vary widely, and it's going to depend on the degree of the pulmonic stenosis, the size of the VSD, and pulmonary and systemic resistance. So the VSD is generally large, so the pressure in the left and right ventricles may be equal. In this case, then, the shunt direction of the blood depends on the difference between the pulmonary and systemic vascular resistance. So if the pulmonary vascular resistance is higher than the systemic vascular resistance, then you're going to have right to left shunting of blood. Okay, so then if your systemic vascular resistance is higher than your pulmonary vascular resistance, then you're going to have shunting of blood from your left to your right. So now there is a pulmonic stenosis in this defect. So there's decreased blood flow to the lung. So there's less oxygenated blood that returns to the left side of the heart. So the clinical manifestations then would depend on the degree of the pulmonic stenosis. Depending on the degree of the pulmonic stenosis, it will determine the degree of your cyanosis, how severely cyanotic they are. Some infants may be severely cyanotic at birth, and some may have mild cyanosis that may progressively get worse in the first year of life as the pulmonic stenosis worsens. You're definitely going to hear a murmur. Now with the TOF, the child may have blue spells or TET spells, TET spells. These are acute episodes of cyanosis and hypoxia. They're rarely seen before 2 months of age, and they usually occur most frequently in the first year of life. So what happens is that in this area, what happens is there's spasms, and it's called the infundibular area. You get spasms in that area, so it decreases your pulmonary blood flow, and there is right to left shunting of blood. So blood shunts from the right side of the heart to the left, so you have unoxygenated blood going to the left side. So TET spells occur when the child's oxygen requirements exceed the blood supply. So usually during extreme agitation, if you're inserting an IV or you're doing any kind of invasive procedure and the child is crying, or during feeding, they can experience these TET spells. So when they do have these TET spells and they're becoming severely cyanotic, if you're inserting an IV, you want to stop and calm the child and give them some oxygen and place them in the knee chest position. And in your book, you have a picture of a parent holding their child in a knee chest position. So what the knee chest position does, it reduces the cardiac output by decreasing the venous return from the lower extremities. And so there's increased systemic vascular resistance. So when you have increased systemic vascular resistance, this diverts more blood to the pulmonary artery, which is good. So you want to place them in that knee chest position because it reduces the cardiac output by decreasing venous return from the lower extremities, because venous return has little oxygenated blood, and it increases systemic vascular resistance, which diverts more blood through the pulmonary artery, and that's what you want. All right, so now we're going to move on and talk about tricuspid atresia. With tricuspid atresia, remember, this is still a defect where there's decreased pulmonary blood flow. Tricuspid atresia is often associated with other defects like pulmonic stenosis or transposition of the great arteries. But that's just incidental information. You just need to know that. So with tricuspid atresia, the valve does not develop. So here you can see there's no opening, you know. So tricuspid, so there's no communication then from the right atrium to the right ventricle. So the blood will end up flowing through an ASD, atrial septal defect, so that's unoxygenated blood, or it'll flow through a foramen ovale to the left side of the heart. And also you have a kind of like a VSD here. So the blood flows through the VSD to the right ventricle and then to the lung. But really the VSD only allows a modest amount of blood through the right ventricle and pulmonary artery for oxygenation. So the pulmonary blood flow is usually decreased, even though you are getting some blood coming from the VSD. So obviously you have mixing of unoxygenated and oxygenated blood in the left and the right side of the heart. So you're going to have systemic desaturation. Now, if there is a pulmonic stenosis, because it's associated with this defect, so depending on the degree of the stenosis, there will be decreased pulmonary blood flow, which that is not good. That makes it even worse. So the clinical manifestations would be cyanosis is seen in the newborn period. They may be tachycardic and dyspneic. Older children will show signs of chronic hypoxemia with clubbing. And the neonate who depends on that PDA to receive blood to the lungs will receive, usually they'll be in the hospital, so they'll usually receive continuous infusion of prostaglandin E, and that keeps that PDA open, that patent ductus arteriae open, so they can get blood going to the lungs and get oxygenated until till surgery can be done. They'll have the prostaglandin till surgery can be done. All right, so now we're going to move on and we're going to talk about infective endocarditis, also known as bacterial endocarditis. And so infective endocarditis is infection of the valves in the inner lining of the heart, and it can damage or destroy the heart valves. So it affects children who have had surgery to repair cardiac defects. And what happens is they develop bacteremia as a consequence of that bacteremia, they develop infective endocarditis. So it commonly affects the mitral and the aortic valves, and children with indwelling catheters are at risk for developing infective endocarditis because that's a foreign invasive um, foreign body in their body, so they're at increased risk for developing bacteremia and then infective endocarditis. So if they do have infective endocarditis, they'll get high dose of IV antibiotics for 2 to 8 weeks to make sure that the bacteria has been eradicated. If the antibiotics are unsuccessful, then you're going to have heart failure or valvular obstruction can occur, and or recurrent systemic emboli can occur. So then in this case, surgical intervention is required. All right, so now we're going to really move on and talk about nursing management. So as a nurse, you want to reduce the child's cardiac demand. So that's really important. You want to reduce their cardiac demand. So you want to administer their cardiac medications and diuretics and allow for adequate rest. And you want to make sure that they have a quiet environment. So whenever you're providing care, you want to organize your care to allow that the child has uninterrupted rest times. You don't want to always be in there bothering them. So in order to improve your the child's cardiac function, you're going to administer digoxin. So, and when you do give digoxin, you want to always calculate the safe dose ranges and make sure it's a correct dose. So this is a med where you're going to have a double check with another nurse to make sure that you are giving the correct dose. And you're also, before you even give digoxin, you are going to count their heart rate. So you don't get a radio pulse, you don't get it off the cardiac monitor. You're going to actually listen to the heart rate and you're going to count it for 1 full minute. All right? So, and the doctor will write, if heart rate less than, depending on their age, if the heart rate is less than this, hold the dig. But for the purposes of our lecture, for infants and young children, you're going to withhold the digoxin if their apical pulse is below 90 to 110. And for older children, you're going to withhold the digoxin if their heart rate is less than 70. All right? So, one thing to remember is that the safety margin between toxicity and therapeutic and lethal dose is very narrow. That's why it's a double check. So you want to assess for signs of toxicity in infants and children. So, and signs of toxicity are, and these are common signs, are bradycardia, poor feeding, anorexia, nausea, and vomiting. So really some of the signs for toxicity would be, primarily nausea and vomiting. So isolated vomiting not related to feeding does not necessarily indicate toxicity. So usually there's less interest in eating, and usually they have, the child will have a decrease in oral intake. So common signs of toxicity are bradycardia, anorexia, and nausea and vomiting. All right. All right, nursing management, continuation. So all right, so if the child is on an ACE inhibitor, you want to monitor their blood pressure before and after the medication is given. So you want to monitor before. You want to get the blood pressure before, because if the blood pressure is too low, then you don't want to give it. So there'll be some written parameters. The doctor will have some written parameters of when you should withhold it. So you want to monitor for hypotension before and after. You want to notify practitioner if the blood pressure is too low, and then you want to withhold the dose. If the child is on a diuretic and an ACE inhibitor, you want to monitor their renal function. So you're going to look at their lab values. All right, so some of the other things that you're going to do to decrease cardiac demands, and that's your goal as a nurse, is you want to decrease the child's cardiac demand. So in order to do that, how do you do that? You maintain a quiet environment. And kids with cardiac defects need to conserve their energy for feeding. So you need to organize your nursing activities because you want to allow for uninterrupted sleep. So as for feedings, you don't wait till the infant is crying because they're hungry. You want to make an effort to plan the feedings around their sleep and their wake patterns. So you should probably feed them probably every 3 hours. So wake them up. If it's beyond 4 hours, you need to wake them up and feed them. So also you need to take their cues. If they're sucking on their hands, then they're hungry. So feed them. So it's important to remember also that infants with heart failure will tire easily, so they may need smaller feedings more frequently. So smaller feedings maybe every 3 hours. So you don't feed them more than 30 minutes. All right, so you only feed them for maximum 30 minutes. But if they're at 20 minutes and they're pooping out, then just stop. You have to look at their cues. So with cardiac kids, if they're not getting enough calories, you may have to gavage feed them, or you may have continuous NG feeds at nighttime, or they may have a nasogastric tube in all the time, and then they may say, okay, we'll feed them till they poop out, and then till they get tired. That you see that they're getting tired, and then you can gavage the rest. So it'll depend on what the doctor orders. Now, some infants may need more calories per ounce. So instead of giving them 20 calories per ounce, the pharmacy, or you may even add some more MCT oil to create more calories per ounce. So they may require 24 or 28 calories per ounce. So the doctor will determine that. So other ways that you're going to decrease their cardiac demands would be, you want to decrease their stress. Keep them happy, keep them calm. You want to encourage your parents to hold and cuddle the child to keep them calm. This also promotes the parent-child relationship. With older children, you will need an explanation of what equipment is. You want to prepare them for any tests, and you want to provide them with quiet playtime and rest times. And of course, whenever you give them an explanation should be geared toward their age and appropriate development. So if a child is gaining weight, this indicates their cardiac demands have been decreased. So gaining weight is good. Unless they have pitting edema and unless they have fluid in their lungs, that's another kind of weight. But if they're gaining, weight, the right kind of weight, that indicates their cardiac demands are decreased. So if they do have edema, you want to prevent skin breakdown. So you want to turn them every 2 hours, reposition them. All right, so you want to reduce respiratory distress. So you want to carefully assess their respiratory status. If they're on oxygen nasal cannula, mask, or tent, it should be humidified. And also to facilitate chest expansion, you should elevate the head of the bed at 45 degrees or have them in an infant seat. For children, you could put them in high Fowlers during wake time to avoid and also avoid constricting clothes. So have loose clothes. So you want to prevent respiratory infections because they can exacerbate heart failure. So ill people should not have any contact with with the child who has a heart defect. And you always want to teach families and friends to practice good hand washing, so good hand hygiene, and they'll be put on antibiotics as needed, and they should always have their immunization should be up to date. So also good nutrition is critical, because they have high metabolic needs, high metabolic rate because of the poor cardiac function. They have a high heart rate, high heart respiratory rate, so they have high caloric needs. They lack energy, and they have low cardiac reserve for feeding, so they fatigue easily, and fatigue limits their ability to get enough calories. So you want to make sure they're well rested before feeding. As soon as they wake up, feed them. Don't let them cry, because they can't tolerate it. It's best to feed every 3 hours. Use a soft nipple, so that would mean a red nipple or a preemie nipple, because the red nipples have a larger hole. The preemie nipples are softer, so if you use those nipples, they expend less energy for sucking. You always want to feed them in an upright position, and once again, don't feed them more than 30 minutes. If they're not getting enough calories, they may require gavage feedings, or they may require more calories per ounce. So also during feeding, if they are stressed or tired, or if the respiratory rate is greater than 60, you need to gavage feed. And then I already talked about adding additive like Polycose, possibly, or pharmacy might add more calories per ounce in their formula. It's important to remember that when they do increase the calories per ounce, it needs to go slowly. They need to increase the feeding slowly, because you'll prevent diarrhea, because if you increase it too quickly, they can develop diarrhea or intolerance. All right, so that's important to remember. So if they're increasing their calories per ounce and the child is having diarrhea, you need to make sure that you let the physician know immediately. All right, so now in our last slide, we want to monitor their hydration status, because most likely they'll be on diuretics, and you want to monitor very strictly their intake and output, and you want to measure their weight every single day at the same time, and usually nude. You want to monitor their electrolytes, so you want to use the same scale. So usually the scales will have a number on it, so you want to make sure you weigh them with the same scale. You want to limit salt intake, and I'm not sure if I said you want to monitor electrolyte imbalances, especially if they're on diuretics. And you want to educate the parents on foods like high salt foods. You want to discourage salty foods. You want to educate parents on what a well balanced diet would look at. So a nutritionist will come and see them. And last, you want to make sure that you support the family. You want to provide them with anticipatory preparation to parents and children to reduce their stress and anxiety. And you always want to make sure that you communicate the child's progress often and provide reassurance to the parents. So that is the end of week 2, part 2.